Good day, my name is Mike Perry from African Reptiles and Venom. Today we're going to discuss a snakebite scenario where you get bitten by this particular snake, a puff adder. These bites normally take place in the evening when these snakes move around and people step on them. So you get toe, foot, ankle, lower leg bites from these snakes. The venom is mainly cytotoxic. The venom destroys the body tissue. So what happens is the venom breaks the cell membranes. It causes a lot of pain. The venom perforates the vascular system, and fluid from the vascular system leaks out into the body tissue, causing you to swell up. So with this type of bite, you're going to see pain and swelling. The syndrome is described as painful progressive swelling syndrome. Now, puff adders are very common snakes in Africa. They cause a lot of snake bites. The death from these bites are fairly low. We normally see children dying, sometimes older people or people with comorbidities. The death is caused by, firstly, hypovolemic shock. The tremendous swelling reduces the amount of circulation, and then there's not enough circulation to the organs start dying, and then you go into hypovolemic shock. Second thing that can cause death is septicemia from the bites. If you don't get it looked after properly, you can develop septicemia. And the third thing we see is bleeding from these bites. In certain parts of Africa, we get quite a bit of bleeding from these bites, and I know of patients that have died within 4 hours from bleeding from a puff adder bite. Now, these snakes have large hinge front fangs. These snakes are typically a snake of about 90 centimeters to slightly over a meter. In southern Africa, it's rare to get one of these snakes longer than 1.4 meters, but we have recorded 1.6 meters. In East Africa and West Africa, you do get puff adders that can often grow to 1.5 meters in length. This snake will have fangs of around about 15 to 18 millimeters in length. They're hypodermic needles. You can see the pattern of the snake is there to break the outline of the snake. It's got these chevrons on the back, and this will help in the snake's camouflage. These snakes are ambush hunters. They don't chase after prey. They wait for prey to come within strike range, and then a lightning fast strike will secure the prey for this snake. These snakes eat virtually anything. They'll eat cold-blooded prey like lizards, other snakes, and frogs and toads. But they're far more partial to warm-blooded prey. They love to feed on rodents. So rats and mice make up the majority of food items they will hunt. They're actually very good pest control. It's just a pity they also cause a lot of snake bites. Now, with the cytotoxic venom, the venom that attacks the body tissue and causes cell membrane breakage and perforation of the vascular system, the thing that you do not want to do is to tie that thing off. So no tourniquet in this type of bite. Second thing that we want to avoid is to actually do pressure immobilization, because what's happening then is you keep the venom at that bite site, and we want the venom to rather move away, so the venom gets diluted. If the venom is diluted, it will cause less tissue damage. So no tourniquet, no pressure bandaging. So with the first aid for this snake, we want to just get to hospital. That's all we want to do. Now, there was a study done in South Africa by Dr. Roger Blaylock, and he came up with another treatment for a finger or hand bite from a snake with cytotoxic venom. And that treatment regime is the following. Firstly, you're going to identify the snake correctly. It's a snake with mainly cytotoxic venom, and the bite was on the finger or the hand. Right, your first aid then is going to be to elevate that hand and vigorously exercise that hand for about 10 minutes. What happens is you activate the lymphatic pump. Lymphatics start absorbing and moving venom out of the finger, reducing the quantity of venom in the finger and giving your finger an opportunity of survival, which otherwise you won't have if you just leave it alone. A lot of people are skeptical about this, but we have tried it, and it seems that it has had a benefit with the people bitten here at the snake farm. So that's the puff adder. The puff adder, common night adder, the Mozambique spitting cobra, and the stiletto snake. Those 4 snakes cause most of the snake bites in southern Africa, and these bites are cytotoxics. So for those snakes, you're going to just get the person into a vehicle and drive them straight to a hospital. If possible, if the journey is long, you can maybe contact the hospital. They can send the ambulance, and you can meet the ambulance along the way. Death in these bites, as I mentioned, is low, although we do see some deaths occurring. So that's the cytotoxic bite, the one that causes pain and swelling. The snake you see me holding here is the Boomslang. It's Africa's most venomous snake. The snake has a very powerful hemotoxic venom. That venom attacks the clotting factors, removes clotting factors from the circulation, and that causes the viscosity of the blood to change. So the blood was thick and then it becomes thin like water. That's your first step. Second step, the hemotoxic venom will attack the vascular system, perforate it, and the blood with no clotting factors then starts leaving the circulation, and you get a bleeding syndrome happening. Now the venom is normally slow acting because the venom is injected in very small quantities. If it was injected in larger quantities, we'll see the action of the venom a lot quicker. With the hemotoxic venom, the first aid will just be to get to the hospital. I know of a person that was bitten, and he took a 4-hour journey from where he was bitten to a major hospital in Johannesburg to get treatment there. And he arrived at the hospital quite fine. The snake you see is called the Snouted Cobra. These snakes have a venom that's mainly neurotoxic. That neurotoxic venom will attack the nervous system in the body. The attack takes place at the neuromuscular junction. Now you get presynaptic venoms and postsynaptic venoms. The presynaptic venoms were first discovered. They're called alpha neurotoxins. Postsynaptic venoms are called beta neurotoxins. They were later discovered. Doesn't matter what venom it is, beta neurotoxin or a alpha neurotoxin. What the venom wants to do is to block the signal from the brain, so the muscle doesn't get a signal from the brain to work. So with these venoms, if that venom is effectively blocking that signal, the muscle gets no signal to work and you are paralyzed. If you watch a person bitten by a snake with neurotoxic venom, you'll notice over a period of time, the person becomes weaker and weaker. So the syndrome is described as progressive weakness. Now with these bites, the venom can be fairly quick acting. And for these bites, we want to delay the action of the venom. And there are 2 main things we can use for delaying the action of the venom. The first is pressure immobilization, a technique that was developed in Australia. And the second method is the placement of a tourniquet high up on the bitten limb. Tourniquets are very controversial, but we have used them very successfully here at African Reptiles on Venom with a black mamba bite and with a Cape Cobra bite. With both these techniques, the idea is to stop the venom from reaching the vital organs in the body. And we will do another video where we show you where we do that to effectively stop the venom from absorption into the body. So this is the neurotoxic Snouted Cobra. Our non-spitting cobras normally have a neurotoxic venom. So if we look at the Snouted Cobra, the Enthusiast cobra, which is a close relative, the forest cobra and the Cape Cobra, these are cobras found in southern Africa. These snakes have a venom that's mainly neurotoxic. And then of course the black mambas, all the mambas have neurotoxic venom, but the black mamba have very potent neurotoxic venom. And those are the ones we got to watch out for. These are the snakes that if you delay, you might die fairly quickly from the bite. Or you might be paralyzed so that you are unable to help yourself. So we're going to show you how we will apply pressure immobilization as well as a tourniquet. We're going to discuss pressure immobilization, what you need to do and not do when you are going to do this kind of technique. Technique developed in Australia. So there are Special bandages that we use. This is a sure press. You get also the smart bandages. These bandages have printed at certain intervals a rectangle. And when you place the bandage, what you're going to do is you're going to first stretch the bandage so that the rectangle becomes a square. And then you place the bandage and it gives you the correct pressure. We need between 50 to 70 millimeter mercury pressure on the bitten limb. The method that is described from the World Health Organization is to bandage from the bite site up the limb. So bandaging will start here where the bite has been, and we're going to stretch this bandage to get those rectangles into a square, and we're going to start bandaging. Then as we go up the limb, we're going to start overlapping this bandage onto a new section of the body. And keep those rectangles nice open squares. And this is what we're going to do until we get to the top of the limb, and then the bandage will be ended off, and the limb is then kept straight. We might even splint it, keep it straight. The patient is then placed on a stretcher. The patient is then carried to a vehicle and then transported. So for this type of treatment, the victim is doing nothing. The victim is a mannequin that I'm working on. Right? He's not bandaging, nothing. He's just watching what we do. All right? And he's going to cooperate, get on a stretcher, we take him to the hospital. Okay, so that's pressure immobilization. The idea is here that we provide superficial pressure on the lymphatic system. Most snake venoms with medium and large molecules, once they get injected into the tissue, the lymphatic system will absorb the venom and then transport the venom. Your lymphatic system is a shunt between the body tissue and the circulation. So when you get blood pumping into the body, that blood at the capillary level release into the outside of the circulation. It will release the lymphatic fluid. Lymphatic fluid bathes the body cells. That lymphatic fluid is then shunted back to the circulation by means of the lymphatic system. So the lymphatic system will absorb medium and large snake venom molecules and start transporting it, and then in the right and left subclavian vein, all the lymphatic fluid pours back into the circulation. The circulation receives that venom, and then the circulation will deliver the venom to whatever is the target site for that venom. So this is a method of slowing down the absorption of the venom from the bite site into the circulation. Right, it needs to be done fairly quickly. No movement from the patient. The patient needs help. You're going to bandage him. You're going to place him on the stretcher. You're going to transport him to the hospital. Right, pressure immobilization. This is the method that is the gold standard for treating neurotoxic bites according to the World Health Organization. Now, the method that we use here is to bandage from the bite site up the limb. Most of the times this is going to work fine. But in certain snake bites, even though they're neurotoxic, they also contain cytotoxic components. And then you get swelling. And then the swelling goes underneath the bandage, and then the bandage becomes too tight. And that is not good either, especially if you're a long way from any help. So the preferred method that we use is as follows. With my pressure immobilization, I'm going to have a short bandage like this. These are one of those bandages that stick onto itself. All right. Person is bitten. I'm going to take the short bandage. All right, and I'm going to immediately put it on the bite site, or just above the bite site, to get this initial pressure on this bite site. All right, I'm going to make this fairly tight to get that pressure and to hold the venom there. Okay, now that I've done that, now I'm going to use this bandage. But now I'm going to bandage differently. I'm going to go from proximal to distal. So I bandage from the body down to the bite site. So we will start the bandage in the thigh. Fast off now. Right, once again, we look at these indicators and make sure that we get the correct pressure on the limb. We open those rectangles to a nice square. Then we're going to once again bandage, but bandage down to the bite site. Right, when we get to the bite side, we're going to end this bandage off, tuck it in on itself there. Now, swelling starts from the bite site and it goes up the limb. If this swelling starts here and it goes underneath the bandage, then the bandage becomes too tight. So what I'm going to do then is, there's too much swelling, I'm going to remove this, and I'm going to now loosen this bandage in front of that swelling. Okay, but the rest I'm going to leave in place. So I'm not releasing the venom to go further up. I'm just easing the pressure underneath the bandage because there's too much swelling on the bite side. So this is the method we prefer when we do pressure immobilization. And once again, same rule applies. Okay, no movement from the victim. The victim needs help. The victim must be bandaged, transported by a stretcher, transported by a vehicle to the medical facility. Today I'm going to discuss something that's very controversial in first aid for snakebite. It's the use of a tourniquet. We've used a tourniquet very successfully in the treatment of both a black mamba and a Cape Cobra bite. We use a BP cuff as a tourniquet. You've taken a bite and the tourniquet goes onto the upper arm or upper leg, depending on where that bite is. There's a little tap on this bulb, close the tap, and then we're going to pump up this bladder here to stop the circulation so that we have no pulse. So nothing enters and nothing leaves. By doing this, you trap the venom in this part of the body. It's away from the vitals. You now have a 2-hour window in which you can get to a hospital and nothing will happen to your arm. And the reason I say this is because orthopedic surgeons do exactly this. You've crushed your hand, you go to the hospital, the doctor is going to perform an operation to repair your hand. He stops the circulation because when he cuts you open, he doesn't want you to bleed. He repairs 1, 2, 3 fingers, he runs out of time. What he does now is he removes the tourniquet, gets the circulation to restore for 15 minutes, and he repeats what he's done. He stops the circulation and finishes his operation. Then your arm doesn't fall off 1 or 2 or 3 weeks later because of the tourniquet. Two things are very important. The doctor uses a BP cuff as a tourniquet. Doesn't use a piece of copper wire or a piece of string or a boot lace or something very thin. It's something broad. And second, the doctor knows when he's placed it, he knows when he's going to release it again. If you have a bite like a mamba or Cape Cobra and you use this as first aid, after 2 hours traveling to the hospital, if you haven't reached the hospital, you cannot remove that tourniquet. You'll get a venom rush. A venom rush means the signs and symptoms we normally get that spread out over a longer period of time will happen in a compressed amount of time. You can't survive a venom rush out of hospital, so you need to stay with the tourniquet. Right, worst complication is you leave this on for 6 hours or longer. You could then have an amputation. Most of the time you should get to a hospital within a period of 6 hours. Let's say it's taking you 3 hours to reach the hospital. This part of the body that was separated from the rest of the circulation has turned into acid. All right. You take the tourniquet off, this acid poisons your body. Medical term for this is acidosis. Now, doctors deal with acidosis every day of their life. People get trapped in motor vehicles, they get cut out by paramedics, they get delivered to the hospital. The doctor deals with the acidosis. Don't worry about acidosis. Doctors have drugs and protocols to treat acidosis. What you're concerned is about your life. You keep it on. You get to the hospital, you say to the doctor, listen, it's taken me 3 hours to get to the hospital. This tourniquet has been on for 3 hours. That means I'm going to have acidosis. So, number one, get the drug into the drip to fight the acidosis. Number two, with these bites, we do not remove the tourniquet. Right, you get a venom rush. So what we do is we first get the antivenom into the patient. Once the antivenom has gone into the patient, then we slowly release this tourniquet, and we do it over a 10 to 20 minute period. Slowly, every few minutes, just relieve the pressure until at about 20 minutes you can remove the tourniquet altogether. As I said, we've had very great success with both a black mamba and a Cape Cobra bite using a BP cuff as a tourniquet. In both these cases, the antivenom went into the patient. The tourniquet was then slowly released. There were very minor signs and symptoms because the antivenom was already circulating. And both those cases, the patient was released the next day after the bite. So for me, that is a perfect outcome. I can't have a better outcome than that. So for us, we really swear by using a tourniquet in a neurotoxic bite.